BC's vaccine management digital solution and take us through your great and innovative discussion today.
Hi, everybody. Good morning. My name is Tuason, registered nurse and director of clinical architecture and innovation at the Digital Health Strategy Office with PHSA and MOH. Today, I'm fortunate to share with you BC's story of its COVID-19 vaccine program and digital solutions on behalf of all the teams who played a role. If you or your loved ones ever went online and registered for your vaccine, received booking notifications and accessed your vaccine record and card online here in BC, then you have participated in the programs that I'll be addressing today. I gratefully acknowledge that I'm calling from the traditional and ancestral lands of the Musqueam, Squamish, and Tsleil-Waututh nations in this place currently known as Vancouver, where I live, work, and play. First Nations have been responsible for stewarding this land since time immemorial, and I give thanks as an uninvited guest on these lands. I have nothing to disclose, but in addition, I would like to reflect on our success coming together in the face of a pandemic, and would be remiss not to acknowledge our healthcare workers for all you've done and all you've gone through to continue providing care. Thank you. And I'd also like to remember those we have lost to COVID, and I acknowledge our personal personal sacrifices and challenges we faced during these unprecedented times. BC does have some incredible support resources, and they're made available on our government websites. I know EFAP and some of these resources online have certainly helped me. And so on with our presentation about our COVID program here in BC. Every time Dr. Bonnie Henry and Minister Dix stepped up to the podium to guide people in BC through the pandemic, a dedicated team of leaders, clinicians, service agents, writers, communicators, designers, technologists, and volunteers stood behind them to help people follow public health orders and stay safe. The stories of BC's success in the face of the pandemic is a testament of teamwork around people-centered goals through a global emergency. Together, through tight coordination between leadership, operations, communications, and digital solutions, we addressed key challenges from reaching at-risk remote and Indigenous communities, managing inventory and supply distribution around the province, to standing up and managing capacity of vaccine clinics, large and small, across regional health authorities, and then later with our pharmacy partners across 1,100 pharmacies. Across sectors at joint tables, all reported up to Dr. Henry, Minister Dix, and Dr. Penny Ballum. Clear leadership and governance were key because the stakes were high. Public health orders stalled whole industries and asked people to stay away from work, from travel, and their loved ones. People needed information in the simplest terms to help flatten the curve in the way that met their needs. We used every medium possible for maximum reach. Press conference live streaming, social media posts with over 300 million views, plain language summaries of provincial health orders online with over 200 million views, news media releases, contact centers with live agents on the other end answering calls, and telephone and video town halls connecting people to their local leadership. Creating quality, inclusive information was complex. Information was made available in 12 languages. American Sign Language happened during live streams. But in response to the seemingly endless questions, the team stayed focused and kept the message positive and consistent, encouraging people to do the right thing in extraordinary times. The news of the COVID-19 vaccine's arrival came in the absence of any system capable of vaccinating 4.5 million people twice over, and then with a booster within a 12-month period. In December 2021, we first started with local communications and email to healthcare workers to attend worksite clinics and use a simple online form for vaccine record documentation. We knew then we needed a system for much larger volumes to engage and vaccinate up to 65,000 people a week at the height of the campaign. And the system had to be simple and flexible enough to prioritize the most vulnerable people. So a blend of public servants and like myself and private sector experts worked day and night to build the Get Vaccinated system to register and book vaccinations. People could go online and self-register. The provincial call center was stood up, and at the height of the campaign, agents handled 50,000 to 70,000 calls a week. Health authority and pharmacy providers use the ImmsBC digital solution to manage notifications, reminders, appointment scheduling, inventory documentation, and real-time reporting and analytics by our tremendous provincial analytics and regional support teams. It only took us 9 weeks to go from product goals on a virtual whiteboard to an actual minimum viable product in a live environment. We applied the agile methodologies and the Scrum framework with 2-week and 3-week sprints to release new features and enhancements based on user experience, operational data, and the ever-evolving vaccine strategy. So 60 releases and hot fixes later, we continue to keep up with the ever-evolving needs of our vaccine campaign, with vaccine for the 6-month to 4-year-old group just around the corner. And change management support and training were needed for over 24,000 users to transform the way they offered vaccine to their communities and apply these digital solutions. To support frontline workers and reach people in the north, a direct line was added to allow people to register and book for immediate vaccination where supply was available. As the vaccine program continued, constant operational and technical adaptations were needed to prioritize frontline workers, areas with outbreaks, manage vaccine shortage, and then to reschedule clinics due to severe weather. So for those that live in BC, you'll remember our summer of 2021, severe weather. We had heat domes, wildfires, and floods. Behind the scenes, though, there were amazing stories of problem solving, getting to communities that were cut off. We also offered online tools for people returning to BC and newcomers to submit out of province records for vaccine record completeness. But throughout our pandemic, our partnership earned a reputation for quickly building tools like long-term care worker registries, on-farm safety protocols for agricultural workers, so people and businesses could stay within provincial health orders and keep the economy moving. As vaccine rates began to plateau, however, leadership made a bold decision to order that only vaccinated people, those with 2 doses of the vaccine, could enter non-essential services like restaurants and gyms. So in the space of 10 days, the team created a way of issuing visual proof of vaccination that could be easily checked at restaurants and events. The BC vaccine card was accessed online, by phone, or in person, and it could be downloaded and printed. So as 4 million vaccine cards were issued within days of the program's launch, businesses were informed on what to do with scanning QR codes with a verifier app. And then rates began to climb again. In terms of privacy by design, we protected people's personal information and worked with systems that manage sensitive information, having our privacy and security officers at the table with us as partners too. And then to ensure quality throughout the campaign, research, especially focusing on equity, was done by talking to people about how the service was working for them at each step of the process. And this included seniors, First Nations communities, and people living on the margins of society about their needs and experiences. So as a result of our joint efforts and commitment, BC is emerging from the pandemic with the following measurable outcomes. One of the best protected populations in the world with a 90% vaccination rate. As of April 8th, almost all provincial restrictions were lifted, in large part due to this high vaccination rate. As of February of this year, the Get Vaccinated and ImmsBC platforms had supported over 4.5 million people registered, over 35 million SMS text notifications, 18 million email notifications, over 9.7 million booked appointments, and almost 300,000 BC vaccine cards were printed and mailed to people who didn't have digital tools. So we strived wherever we could to enable equitable access. All this while keeping people at the center of our work and achieving high satisfaction rates. And this is where I'm the most proud of everything we accomplished as a province recently. 97% satisfied or very satisfied with overall experience of getting their shot. 87% provider satisfaction from almost 900 respondents. And I would have to say personally, a justifiable cost per capita, saving hundreds of thousands of lives from serious illness, hospitalization, and possibly death. Our partnership continues to learn at our joint tables and from British Columbians based on their feedback from our online, in-person, and phone-in service options. So we can gather success factors and tailor our supports as we transition to a post-pandemic phase. We help flatten the curve. We help people get vaccinated, and we kept the economy going and are now returning to a new sense of normalcy. And as we saw in our joint efforts against COVID-19, we proved we can positively impact our health and well-being when we work together and put people first. Thank you, and I look forward to your questions.
Thank you, May. Great presentation. We appreciate you sharing BC's vaccine management digital solution. Up next, we're welcoming Dr. Cathie-Kim Lee and Jane Park with a hospital for sick children to share more about innovative work that happened during COVID-19. Please feel free to add comments or questions into the chat during our presentations. And at this time, I'll pass it over to Dr. Lee and Jane to take us through your work. Thank you.
Thank you for the opportunity to present our study on the innovative pediatric emergency department triage system in the COVID-19 era today. So before we begin, I would like to declare that there were no conflicts of interest for this study. The pilot project on the digital front door was funded by the Ontario Ministry of Health, and our evaluation study of this platform was funded by the Pediatric Consultants Partnership CPA grant. We would also like to mention that no members of the Digital Front Door project leadership are on the study team. With the start of the COVID-19 pandemic, there has been heightened interest, research, and funding in virtual care with the hopes of reducing infection transmission. Not only was virtual care the priority for the Canadian Institution of Health Research, but a call for rapid development of virtual care was also implemented by the Ontario Ministry of Health. So the Hospital for Sick Children's Emergency Department responded with various implementations of virtual care, such as virtual follow-up, virtual consultations, and finally, the digital front door urgent care, which is what our evaluation study is on. As you can see on this slide, this is what the digital front door platform looks like on a mobile device. It is a triage system which presents symptom checkers for the users to fill out. And the goal of such triage system is to direct patients to appropriate care depending on the level of severity. Now, the users could be directed to 3 different pathways once they have entered the symptoms into the symptom checker. They can be directed to 1, their primary care physician, 2, virtual care at the Hospital of Sick Children's Emergency Department, which is through a video call, or 3, an in-person care in an emergency department, not necessarily at the Hospital of Sick Children, depending on their geographical location.
So the goal of our study was to evaluate the experience of the users using our service, the providers, and the organizational leaders. And we used that using the quadruple aim domain. So we wanted to look at the experience of the users, the health of population, the cost, and also the work life of the providers. We also looked at the health equity of the service that we offered and also the outcome of the patients using our service. Our population in our study included 3 different populations. The users, which are the caregivers of our pediatric patients, the providers, which included nurses, physician assistants, and physicians, and organizational leaders. We selected our population with purposive sampling, which means that we tried to get a population that was as diverse as possible. For the users, they completed a demographic surveys and an experience survey. And for all 3 populations, we conducted semi-structured interviews. The methods were actually based on a study that was done by Dr. Rebecca Liu at the Women's College Hospital in Toronto, where they did also study their virtual care offerings.
So our recruitment period for this evaluation study was from May of 2021 to November of 2021. There was a total of 5,400 user entries, where 1,620 user entries were directed to their primary care physician. 813 user entries were directed to virtual care at the Hospital of Sick Children, and 2,176 user entries were directed to an in-person emergency department. We wanted to note that these are number of user entries, not users. So there were users that entered multiple times, either on the same day or different days. During this period between May to November of 2021, we not only recruited users, but also providers and leaders to complete surveys and semi-structured interviews. There was a total of 135 users who completed the demographic survey and 110 users who completed the experience surveys and 14 users who completed the interviews. And as you can see on the slide, there is a breakdown of how many users in the virtual care pathway completed the survey and how many users in the primary care physician or in-person emergency department visit pathway completed the survey. On the other hand, there were 5 providers and 4 leaders who completed the interview. From the demographic surveys, we have found that the majority of patients were of ages 30 to 44, white or of European descent, females, heterosexuals with an income of more than $90,000 a year, and were living in an urban setting. So in other words, areas where there are 100,000 residents or more. Meanwhile, all patients had their own primary care physicians, but only 20% saw their primary care physician before using the digital front door platform. Lastly, most users had average to advanced knowledge of technology. It is important to note that these demographics were based on the users who completed the surveys. So it would be inaccurate to say that these surveys have helped us completely identify who the digital front door is serving, although it does provide us with some idea. Certain populations may not have been represented through the completion of the demographic surveys, as they may have been more hesitant or reluctant in participating in research due to a variety of reasons.
So when we looked at the results of our study, looking at the survey data as well as the transcript for our interviews, the 3 themes that was recurrent for the users were that the users felt like the service was cost and time saving. They also felt like the service was convenient, and it allowed them to receive reassurance for the care of their child. So if we start with cost and time saving, as you can see here, the majority of patients strongly agree that it saved them out-of-pocket costs, and also they felt that they received care in a timely manner. For example, one of the quotes here that you can see from a caregiver, it says, if you're a single parent with multiple children, any trip outside of home is probably pretty onerous. Virtual care just reduces the need for additional resources. Another caregiver is also saying that they felt like the service was much more efficient and time-saving than in-person care, and that if they had to seek in-person care, then they would have to take time off from work. And finally, another patient is saying here, it was awesome because it was quick. Instead of waiting in the emergency department for 6-7 hours, you're able to see a staff pediatrician in a matter of a couple of minutes. Also, here again, you see that the majority of patients once again strongly agree that the digital front door provided them with a convenient option and an easy access to technology and space. For example, one caregiver says, when you got a really sick baby, loading them in the car and bringing them to the hospital can be quite complicated. So now you're in the comfort of your own home while you're waiting to see the doctor. That's a game changer. Another caregiver says that definitely it was less stressful for their child, especially when their children are sick. And they felt like it was more convenient to be at home compared to being in an unknown environment. And finally, a lot of parents talked about reassurance. The majority of the parents in the transcript were talking about the fact that they often knew what to do with their child, whether it was to keep them at home or see their primary care physician, or go to the emergency department. However, having someone to tell them that it was the right thing to do was really something that the caregiver were appreciating from the service. For example, there's a caregiver who is saying, we were told by the virtual care doctor to go to sick kids. We would have gone anyways. It was just more reassuring to get that reassurance first that it was the right thing to do. Another caregiver here talks about also that peace of mind that they were getting. And they also knew that it was okay for them to keep their child at home. However, they say here, helping find a solution to break the fever, that's all we needed, just that reassurance. Taking him to the emergency department would have been a nightmare. So now let's move on to our two other population, the providers and the leaders. For them, there were three themes that came up. The first one is appropriate use of providers, appropriate use by users, and also equity concerns. One of the recurrent themes for providers is a lot of providers were actually questioning the role of virtual care in the emergency department. And in the future, what would be the role of that service? For example, one of our physician assistants is saying here, I think it's also about figuring out the resources that need to go into it and how, as we move forward with this virtual care, how do we distinguish virtual services that we provide as the emergency department at sick kids versus virtual care that is provided by a primary care doctor or a walk-in clinic? The challenge will be to figure out what the role of the emergency department is in particular. Another physician was actually concerned about the safety of offering virtual care in the emergency department. They say here, I truly believe that if this is something that we want to continue doing, put the general pediatrician doing it, put the general family doctors doing it. They should be the one running the virtual care, and it should not be an emergency room virtual care. And the reason why this physician was talking about this is that they said that if a patient needs to be seen by an emergency care provider, then they should also be examined in person. Also, there was also a concern about misuse of the virtual care by our users. For example, one physician is saying people are calling for more trivial things. Another physician was concerned because a lot of parents actually came to the appointment, the virtual appointment, without their child, and they felt like that was a misuse of virtual care. And finally, another physician is saying here, I do think the family need to be aware that this is not a medical visit. It's a visit where we decide whether you need to come and be seen. It's not like every question from the last year that you had, which is what a lot of my last visit have become. You know, it's becoming like I'm their primary care doctor. And finally, there were a lot of providers who spoke about equity concerns. For example, one of the quotes is saying, it's clearly not going to be health equitable. This requires English language, accessible to internet, good cameras, so many people will not be able to engage. Another physician here says, the people that we really need to help are the new immigrants. English isn't their first language. There's cultural barriers. People who are taking 3 buses to get to me. Those are the people you'd love to reach, but you can't. And finally, this last quote is actually very interesting, and it's from leadership. And it says here, often the equity, the diversity, equity kind of consideration are not always practical. So like language translation services, we've thought about it from day one. We need it. We don't have it yet because it's hard to do well. We are aware of the digital divide and who has access to these things and who has a private space, high-speed internet, and stuff like that. But there's not always a good solution to those problems. So as you can see here, the equity was taken into consideration when this service was created. However, not all the steps were taken to make sure that this was an equitable service. So in conclusion, what we found with this study is that there is a very high satisfaction rate among users. The users felt like they could save time, save cost, and they felt like the option was very convenient. However, thinking forward with this, we also need to think about what is the cost of having virtual care in an emergency department for the system. For example, we need the technology to put this into place. And also, there is also sometimes duplication of service. Caregivers might be seeking care with their primary care physician on top of seeking care through the virtual care service. And also, we have to think about the cost for users. What is the real cost for users? You need the devices, you need high-speed internet, and you also need the technological literacy to be able to use the service. And we really want to reach out to the population who need it the most. And that population are the people who live in remote communities, the parents who cannot afford to miss work, the parents of multiple children, the parents who need translation services, for example. And currently with the service that we're offering, we may not be able to reach out to the people who need it the most. And in the future, we also have to think about what's the appropriateness of the virtual care services in the emergency department and who should be staffing this service. Should it be emergency doctors, or should it be the primary care physicians and the physicians who already know their patient, who are seeing them virtually as a follow-up? So there's still a lot of question when you think about virtual care services in the emergency department. And what we want to leave you with is the question of what is the real value of virtual care in the emergency department to patients, provider, and system as a whole. Thank you, and we'll look forward to hearing your questions.
Thank you so much, Jane and Dr. Lee, for sharing your work with the Hospital for Sick Children. Very innovative and important, especially at this time. We do have 1 minute, basically, a short time for questions, and I'll be watching the chat here to see if one pops up. Maybe I'll ask both groups. So over to you as well, May, bring you into this conversation. If there was sort of a summary statement you could leave our attendees with here today, based on your work and thinking about that last slide you just put up, in terms of framing the value going forward, where do you see the need for focus in our health system as we step forward into the next 6 to 12 months to be able to provide and also to measure that value? And I'll start with our colleagues at Sick Kids, Dr. Lee and Jane, and then move to you, May, for your thoughts on that.
So I think the pandemic has taught us a lot about virtual care, and 100%, a lot of users, a lot of physicians do find value in virtual care, and there is a value for it in the future and moving forward. And past COVID, I think virtual care is something to stay. However, we do have concerns regarding everything that the provider did talk about in our study about, first, the safety of this, and also the real value of virtual care in the emergency department. And the reason why is we have to ask ourselves the question, is this really filling a gap in the services for patients? Or is this more of a additional resource that patient can have access to, however, but that could be filled in by their primary care physician or filled in by community services with doctors who actually know their patient properly, and which is safer than seeing a patient for the first time, for example, and offering them virtual services. And for example, the child not being there or not being able to properly examine the patient. So I do think that in the future, moving forward, we need to look at a service that we're offering to the patients. And how do we measure that? Yes, we measure with the satisfaction of the patients, which is what we've seen in our study, but also we'll have to also look at the outcomes of the patients. Are there safety concerns? Are there also increased costs to the system? Are there duplications of services also using this virtual care? So there's still a lot of study to be done with this, for sure.
Thanks. May, your thoughts on, give us a key priority or top priority in terms of how we measure value and where to look over the next 6 to 12 months, regionally, provincially, and maybe nationally.
It's absolutely keeping communications with our public and the people of BC here. It's been really tremendous, that especially the research component, to go out there, talk to parents, talk to folks who live here, in the downtown east side, and really understand with the services we're offering, how can we tailor it to your services? So I think it's really important when we're measuring the value that we start with the people first, and then behind the scenes, we've proven we can make a difference, and we can push rocks up hills. We give a little, we take some back, and in the end, as long as we're meeting what the people are looking for and meeting where they are first, then I think we'll be successful in measuring the value, but then also achieving what we're wanting towards the quintuple outcomes.
Well, great. I'd like to thank all of our esteemed panelists here today. Jane, May, Dr. Lee, for sharing your insights and your great work. Next up, I'd like to invite all attendees to head over to the networking lounge, participate in some lively discussions, and meet with colleagues and virtual connections. You can access the lounge at the top of your screen, and we'll see you there. Have a great afternoon.